am. Okay, given that we don't see any questions, what I'm going to do to transition us into our community health worker panel that will start again at 9 a.m. is I'm going to show from YouTube the advocacy, the public policy priorities that were submitted from the Nevada chapter for the American Academy of Pediatrics. And then that will take us into, and at 9 o'clock, we will start our panel.
And Amanda, if I could just add that we
Yep.
tentatively have Senator Dina Neal scheduled for tomorrow's coffee chat. So if you've got an extra 30 minutes at 7:30 and an extra cup of coffee, please join us.
Yes, thank you for mentioning that. Our morning coffee chats have been great, so we hope that you'll be able to come tomorrow.
Hello, I'm Leanne McAllister. I'm Executive Director of the Nevada chapter of the American Academy of Pediatrics. Thank you for giving me a few minutes of your time for me to present our chapter's advocacy priorities for 2021 and beyond. Nevada AAP pediatricians live and work in Nevada and have dedicated their professional lives to the health of all children. At the end of 2020, the Nevada AAP surveyed our 275 members to learn their priorities and recommendations to foster child health and well-being, achieve health equity, eliminate health disparities, optimize lifespan outcomes, strengthen families, support our communities, and enhance the position of Nevada as a leading state for children. The results of that survey are presented in our 2021 Blueprint for Children, currently available in the advocacy section of our website, nevadaaap.org. Our policy goals promote healthy children. All children, adolescents, and young adults from birth to the age of 26 must have access to the highest quality health care so they can thrive throughout their lifespan. Our policy goals recognize the need for family security and stability. Together, we can work to advance efforts to ensure that parents can give their children the best foundation for their future. Our policy goals recognize that strong communities are the building blocks for secure families and healthy children. And lastly, our policy goals call for the elevation and maintenance of child health and well-being as a priority in our state. The Nevada AAP Advocacy Blueprint organizes our members' advocacy goals into categories. Nevada pediatricians are concerned about a wide variety of policy issues. And when asked which were their top priorities, members responded with the following 7 categories. Gun violence prevention that regulates access to guns, including universal background checks, mandatory waiting periods, closure of the gun show loophole, and mental health restrictions for gun purchasers. Childhood preventative care, including eliminating state laws permitting non-medical exemptions to school entry immunization requirements. Tobacco and e-cigarettes, protecting children by vigorously enforcing laws and regulations prohibiting the sale of tobacco and e-cigarettes to minors. Healthcare access and coverage, especially the critical need to keep kids connected to care by guaranteeing 12 months of continuous coverage for children enrolled in Medicaid. COVID-19, especially prioritizing the funding needed to safely open all Nevada schools for families who choose to send their children back. Immigrant child health, granting access for all children and pregnant women in Nevada access to health insurance, regardless of their immigration status. Substance abuse. Punitive measures that taken towards pregnant women, such as criminal prosecution and incarceration, have no proven benefit for infant health. Treatments and programs aimed at supporting mothers to get and stay clean are what's best to provide the best care for their child. Additional advocacy issues important to members of the Nevada AAP include setting medically accurate mandatory sex education standards to empower young people to make healthy, fact-based choices, and setting school start times after 8:30 a.m. for middle and high schoolers to protect them from the significant effects of sleep deprivation.
Perfect. There's a couple, just a little bit left of that, and I'm going to put the link to it in the chat, but I want to make sure. But I wanted to make sure we got through at least those priorities that you can hear. And I know that Leanne's been available throughout the day. So if you have any questions or would like to contact her, I'm sure she would not mind talking to you about any of their policy priorities. So thank you so much for sharing that video. And now I am happy to turn it over for our morning panel on community health workers. I think I'm turning it over to Hilly.
Yeah. Hi, I'm Hailey.
Hi, Lee. I'm sorry.
Am I able to screen share?
Yes, you should be able to screen share.
Okay. You guys see that?
Yes, you can see it.
Okay, cool. Okay, so we are going to have a panel. We have some special guests here to be our panelists for community health workers during Children's Week. Just going to set up all these screens here. There's a lot going on. There we go. So for those of you who don't know me, I am Hailey Dobbs, and I'm interning with Dr. Kelly Bumgarner at CAA. Most of you are familiar faces at this point, so those that are, thank you so much for everything that you have done over the past weeks, months, helping us put this together. And some of our special guests and panelists today to introduce. I'm going to try and see everyone as I do it, but if you want to give a little wave as I say your name here. We have Senator Orntlicker. I'm not sure if he has arrived. Do not see. Eric Schoen. I see you, Eric. Hello. Brooke Sasser. Hi, Brooke. I see you. Jay Colbert Kossel.
Hello, Jay Colbert Kossel.
Steve Messenger. Hi, Steve. David Nyberg. Hi, David. And Catherine Tika. Hi, Catherine. So these are our panelists for the day, and they have been sent some questions that they're going to go over with us. But first, I'm going to give a brief overview. This is going to be news to most of you, or not news to most of you, but let's start with the basics. What is a community health worker? So community health workers are trained community members that go under many titles and work in many settings. So some of these titles may be community health advocate, and some of the settings, schools, jails, in clinics, in FQHCs, and various settings in your communities. These are professionals that work under the supervision of a licensed provider, like a doctor, NP, PA, and are advocates for members of their own community and are often more in touch with their communities than people coming from outside the community. They provide things that we like to call non-glove services, such as counseling and guidance, and then things like first aid, blood pressure screening, diabetes, health checks. And this is, Dwayne Young used the term non-glove services, and I felt like that really encapsulated the health services that are being provided, and they don't replace the role of a community paramedic or licensed healthcare providers in the community. And then the bill that we're talking about today is AB 191. This was previously BDR 449. And this is advocating for the Medicaid reimbursement for CHWs. So this would be using existing billing codes and assigning NPI numbers, national provider numbers, to CHWs for them to be reimbursed for their services when working under licensed healthcare providers. So I've provided links here, but I'll put those in the chat later too, to the actual bill itself, and then CAA's policy brief on it, which many of you assisted in the creation of. Thanks again for that. And so this bill would increase access to community health workers. Currently, a lot of places can't afford to have a community health worker on staff, but having Medicaid reimbursement in clinics such as FQHCs, where they're already billing Medicaid, that would be increasing access there. Useful. And so now I've done my little spiel. We're going to turn it off to the true experts here. I don't have a specific order that anyone's going to answer in, and it's not like a real live panel where we can have you in a line up front. I wish you could rearrange where people are in the Zoom. But our first question here, if anyone from our panel wants to jump in with an answer to this, share how you became involved and what you do relating to CHWs in Nevada. Introduce yourself a little. Let whoever's ready take it away. Catherine, I see your hand.
Can you hear me?
Yep, we can hear you.
My name is Catherine Tika, and I'm a CHW in Pahrump, Nevada. We are a rural community of about 40,000 people, and I am an AmeriCorps member. My host site is Nye Communities Coalition. And I became involved in CHW work quite by accident. My friend saw a job opportunity and knew I was looking for a job. Little did I know I would fall in love with CHW work because I get to help others navigate through barriers in their lives, such as low income, mental health issues, addiction issues, housing issues, work and training issues, food insecurity, and a multitude of other problems that are preventing them from living healthfully and well. I have experienced many of these problems myself, so I am very keen on helping others by giving them a hand up. There were people there for me when I was down, and now I am paying it forward. So.
Thank you, Catherine.
You're welcome.
Hi, I'm happy to go next. My name is Vassar. I became involved very similarly to her story. It just happened by chance. I heard about a job. It kind of fell into community chess lap as well. And we ran with it. And we do a lot. We started with a small focus on me getting in the jail to help provide resources and navigate coming out and being released, re-entry. And now I don't have so much of a center focus. It's more, I will go where our community needs me. If we get a call from the school that somebody needs some assistance there, I'll be at the school or anywhere I need to be truly. I am in Hawthorne. We're a frontier community of about 4,000 people on a good day, maybe. I question that number daily. But yeah, that's what I do.
Thanks, Brooke. David's got his hand up. He's ready to go next.
Likewise, I came upon being a community health worker kind of accidentally. I was doing pre-screens down at the Reno Municipal Court, and a group of us were sitting around talking about some of the things we do. And one of the community health workers said, "You sound like a community health worker. You should take the training." So I took the training and did the certification and found that so many of the little things that I do on the side just fit in with it. And it was nice to get the training, so I had it organized in my mind about what I was trying to do, and it helped put some other pieces together. But like most of them, I came there not really expecting to be there.
Thanks, David.
So this is Eric Schoen. So this makes me feel so good to hear your stories. You three are rock stars. And for those who may not be familiar with community health workers, this is the kind of passion and kind of commitment that I have seen. So I've been involved with trying to raise the profile of community health workers for, I don't know, 5 years, 6 years. And that comes after 20 years. So now I've been working in rural Nevada for about 25 years, 20 years of trying to develop health and human service capacity throughout Nevada using methods that weren't really working, importing mental health professionals who had come from elsewhere but didn't really understand Nevada, give it a year or two and then leave. And we always seemed like we were chasing our tail, never quite able to develop capacity. What I love about community health workers is they're oftentimes from their communities. They already have this nuanced cultural understanding of where they're from, their people they're serving. They have a passion. They see their communities from a positive perspective. And they're like the Swiss Army knives of health and human service workers. You've heard 3 great examples of how, depending on the need and depending on who's in front of them, they can adjust. That's the beauty of a well-trained community health worker. And so in rural Nevada, in the projects that I've been involved with, we're seeing community health workers really being able to do a lot of the work that wasn't there. And I think we have a chance to build a robust health and human service system capacity in rural Nevada using paraprofessionals such as community health workers. So I'm very excited. This is really great. Thank you guys for starting us off.
Eric, watching your reactions through the last ones was really good. Your enthusiasm showed.
Hi, good morning. My name is Steve Messenger. I'm the policy director with the Nevada Primary Care Association, which is the state's association for federally qualified health centers, or FQHCs as Hiley likes to say. I like to echo Eric. It's hard to follow the real heroes here who are, the community health workers who are on the ground. My story is a very dry policy story of how the state has, slowly increased its investment and support of community health workers. So when I came to the Nevada Primary Care Association in 2015, they had just finished a grant to complete a white paper on the feasibility of a community health worker association. And they had really been focused. There was some great leadership in the Division of Public and Behavioral Health to sort of explore how this could be beneficial for Nevada. And in that 2015 legislative session, the legislation was passed to codify community health workers in Nevada law and sort of establish the outline of the regulatory structure that would govern them sort of once we got the reimbursement stage set. Shortly after that, I was invited to join the founding board of the Community Health Worker Association and really help to set up the training programs, not only that were hosted by the association, but also promote those training programs in the community colleges, and really just been here as a policy cheerleader, ever since my boots hit the ground, and really excited that we've finally come to the place where, now we see some legislation that could actually allow us to make a huge step forward. So thank you for Children's Advocacy Alliance for hosting this. And again, thank you for our community health workers who are giving us the picture of what it really looks like on the ground.
Thanks, Steve.
Hello, and I'm Jay Colbert Classell. Everyone adds an R, but I'm not quite that funny as that guy. But I'm the program manager for the Community Health Worker Association. And my role is to have a very strong association, because we have a lot of things that kind of come up and great ideas and enthusiasm, and then we have high turnover and burnout. And with a strong association, I think we can support the health workers, these frontline workers who are out there. We can go after more federal support money to keep these programs sustainable. For example, Nevada only gets about 70% of the national average of program grants. And it's just our utilization of federal money is very, very low. And by having these sustainable programs that achieve results, we're going to be more competitive in that grant making market. And we're also going to qualify for the non-competitive federal grants. But to get there, we have to have leadership. So my big pitch for today is that the community health workers would get more involved with the association. Let me support and network you with each other. We have a big state, and it's our willingness to reach out across all these distances that that is a true strength and something that other states don't have. We have all these unique little coves, and we get to live in our own little small world, but like the same population size as Ohio. So it's really interesting. And I am so ready to explore this all with you.
Thanks, Jay. Is that everyone's answers? I think so. So we're going to move on to our second question here. And a lot of you already answered this. So if anyone has a part that they didn't mention in their first answer, what populations does your work serve? Brooke mentioned all the hats she wears, every person in Hawthorne, basically. But if anyone would like to go ahead with a different answer here. Yeah, Catherine. You're on mute. There you go.
Sorry about that.
No worries.
The people that I serve are mainly veterans, seniors, the homeless, low income, and those affected by COVID. We have other CHWs that work with the children's issues, but you know, which I'll go into later on. But mainly those groups that I just mentioned. Thank you.
Yeah, thank you. David?
My main job is to work with adult addicts. I work at Crossroads, and we have a 110 bed capacity. If you need beds, we've got available. You know, we're but this. So I usually work with the doing pre-screens and doing the compliance reporting, so we can keep the money coming in. But of a necessity, as soon as you start dealing with you know, the men of the family that need help, you have the rest of the family that needs help. And so I do a lot of data, and I do a lot of reaching out to people, and then suddenly needs come up, and those are the really fun parts, the pieces you didn't expect. So.
Thanks, David.
So I was waiting to see if Brooke was going to go. She might go after me. This might be a good
She's got her 4,000 people. We know everyone.
Well, so she probably works with all 4,000 and tell you the truth.
Exactly.
Right. So let me just, for myself, my own experience, provide a little bit of context. So I work as executive director for Community Chest, a nonprofit that provides probably a dozen or 2 dozen different complementary health and human services throughout multiple counties in Nevada. And I'm also a licensed clinical professional counselor, which is what I used to do before I did all this administrative stuff. And what I found with community health workers is they're able to do about 65% or 70% of what I used to do as a clinician. A lot of my time with clients, the magic of that relationship wasn't because I was so brilliant clinically. It was simply because I was in the same room, willing to listen and walk the journey with those people. And for 65 or 70% of the folks that I worked with, that's all they really needed was a sympathetic ear and somebody to help navigate the different systems. And that's what these community health workers are so good at doing. And it doesn't matter if they're, so you might find a community health worker placed in a food bank, which is what the Healthy Communities Coalition does, is they put their community health workers in food banks. The Resilient 8 Coalition, we're focused on helping folks with opioid use disorders. And so we have both prevention and intervention projects in the 8 different counties that we serve. So we help to hook people up with medication-assisted treatment. We have some remote providers who come through and we help connect them with those services. We have done dozens upon dozens of naloxone trainings throughout the different communities. We're planning an upcoming Nevada Opioid Summit being done virtually by Zoom. If people are interested, you can reach out to me. But they sort of fill in the cracks everywhere. Brooke talked about going to the jail to meet with inmates, which was for us an approximation of the most programs that were started in Washoe County and Carson City. We wanted to do something similar, and our best ability to do that came when we had community health workers, and it works. It works really, really well. So really the question could be they work with all populations. They can work with all possible problems and presentations, and they do it quite well. Brooke,
So Eric, yeah, I'll go ahead and follow you. I assumed at some point today you were going to call me out in some capacity. So here we go. Like Eric brought up some really beautiful points, and community health workers have this ability to be an incredible connective tissue of the community. Yes, probably the 4,000 residents of Hawthorne do know my name and know my face. I make it a point to be out there, whether it's at the jail, ride-alongs with officers responding to crisis calls, or just being a support wherever I can. I go to school events. I go wherever I am needed. I try and be at all community events, things like that, because you never know what somebody might be facing. You never know when somebody might be down on hard times. As much as I serve low income families, I've also served a lot of higher income families who maybe just need that extra help getting into counseling or therapy, or getting to a different place. And we have that ability as community health workers to be so diverse in who we serve in our population. It's in our training to be diverse and to address needs as we see them. And you never know when you're going to come across somebody who does just need simply somebody to hear them and to see them that day.
Boy, it's so hard to present the 10,000 foot level after you've gotten the sort of on the ground view of this stuff. But, you know, community health workers in our community health centers really started out through grants. Once again, this goes back to state investments, grants to support chronic disease. And so the first project was around colorectal cancer screening. And of course, this is a process of some nagging, right? This is you come in and your provider suggests that you take this fit test home and mail it back, or drop off the sample, and it's not a very fun or popular thing to do. And so a lot of patients just need a lot of support. They might need 4 or 5 calls, encouraging them to do this work so that they can get their colorectal cancer screening. The flip side of it is the cervical cancer and mammography screening, and those community health workers were sort of leveraged because they were doing very similar work to reach out to those folks who were missing, behind on their mammography or behind on their pap smear. So chronic disease is one way community health workers can really specialize. They end up knowing a lot about the disease that they're promoting, or the screening that they're promoting. They understand sort of the common issues. If you've called 1,000 people to try to convince them to take their colorectal cancer screening, you kind of know what some of the prime objections and obstacles are. But then we also think about them as being very cultural. Our community health centers are sometimes the only option for undocumented, uninsured residents of the state. And so, you really need to have outreach into those communities, both linguistically and culturally, to help interpret the medical advice that you're being given. And then we think about other cultures. I think about Northern Nevada Hopes and like their needle exchange program and their outreach at the LGBT, clubs and bars. And really, that's ideal for a community health worker to meet somebody sort of where they are in that, nightclub needle exchange situation, and then be able to get them into treatment. So we've seen a lot of success there. And in those kind of, you think about different communities. It could be a rural community. It could be a linguistic or cultural community. It could be the LGBT community. There's community health workers, as we've heard already, kind of for everyone.
Thanks, Steve. I think that sums it up well, that there is community health workers for everyone. And then, as we've talked about, and David, you kind of touched on this, that when you work with the men of the family, the rest of the family becomes a part of that. But how does your work specifically, and this question's going out to everyone, support the health of children in our state, and why should this matter, and why does this matter to Nevadans? Jay.
Well, yeah, I could jump in here. I mean, the starting answer is that there just aren't enough people to support the people of our state. And CHWs is this established, more than 20-year model that is going to increase the workforce so that we can just have more of those personal connections and have more time with people, because we just don't have enough. I mean, if you're a case manager and you have 20 to 40 people on your caseload, you can't really get to know each family and provide support in the same way that a community health worker can. And then another piece to it is touching into a little bit of the macro and some of the other topics that you asked us to explore during this panel, and that's diversity and inclusion. CHWs or CHW positions are a stretch position. And what I mean by that is a job where you get to kind of go up a little bit above the job description and show what you're capable of. And it's not that you're just showing what you're capable of to others, but you're actually learning yourself what drives you when you get access to those stretch positions. And some sectors of our society, you get those all the time. Like if you get to play a school sport, you can win or lose on any given weekend. You can try things, you can make new plays, and there are no negative consequences. But if you're from a community that doesn't have all of those resources, and you go and try something or open a business, you can have lifelong consequences from that. And that's, I think, a huge issue of why we don't see as much inclusion and people kind of moving up into the leadership chains and making these decisions that will improve the direct health of children in our state. And so what CHWs can come in and do is have those direct relationships, have that, like, they're not just, working in a warehouse. Those are great jobs, but, some people are capable of more leadership than that. And as a CHW, they can, use their knowledge of the community, and they can share that information up so that we can improve these services. And then hopefully be recognized and put forward as the leaders who get to make decisions for how we take care of the families in our state.
So if I may, let me return to an earlier point that I made, Eric Schoen again, where I said in my role as a counselor, I felt that community health workers were able to do 65 or 70% of the work that I was doing previously. Jay has a great metaphor that when we're building homes, we don't want our architects doing all the work. There's not enough architects to do that anyway. We have laborers who are able to do that, and the architects who are more expensive, they can work on designing the homes and doing what they do best. So with the laborers, we're able to maximize the talents of the architect. So we all know that we have a mental health shortage, in terms of services here in Nevada. And so one of the ways in which community health workers, I think, can help support the health of children is that if we move them into a mental health capacity where they are working more proactively and able to work with some of the folks on some of those case management issues, it should free up, theoretically, and I think practically it does, it should free up the time of the folks who are trained to work with the more acute cases. And so what you would end up having perhaps is not such a backlog for people trying to get into licensed mental health professionals, you might actually have something that's more manageable, both for the parents of the children as well as the children themselves. So you open up capacity that way as well.
Thank you, Eric. Yeah, Catherine.
Well, I'm Catherine Tika. I see many disparities in wellness. For example, mothers of young children who are low income, and we hook them up for the WIC program for infants and children, and actually shop for them. And we also have child car seat programs and infant crib safety, drowning prevention, pre-K program, and we have a SAFE program for before and after school kids whose parents work. Also, the CHW also helps with youth, hooking them up to YouthWorks, which is a program we have here at our coalition, and which teaches them work ethics and responsibility and life skills. We have a GED program and training for jobs. We also receive training in youth mental health first aid, training in teen suicide prevention. Also, we have a teen drug use awareness program, also for tobacco and e-cigarettes and vaping education for youth. And we receive training in nutrition for families, diabetes and pre-diabetes in children and adults, and the importance of exercise. And anyway, that's my work supports children because I work with the adults who have children, and the children are benefited from my help.
Awesome. Thank you, Catherine. Yeah, David.
You know, one of the things that as a community health worker, I found it, I think everybody's probably seen the video, what is the opposite of addiction? And the answer is connection, but I think putting the word addiction there is too limited. What's the answer to so many of the problems? And it's connection. One of the joyful little things I get to do that we've just arranged, a number of the institutional receivers of food from like the food bank and Whole Foods and the various different places that give food, is by the time they've met their institutional need, they then have food left over. And sadly, a lot of the time this food gets thrown away. I heard about some of this and reached out to some of the grandmothers in some of the lower income areas of the city. And the grandmothers knew who needed it. The grandmothers who take care of kids while, you know, their kids are working and stuff like this. So I get to go home a couple of nights a week with my car loaded up with this and drop it off for Joyce to get, and then they all get together and pass it out. And so this stuff doesn't go to waste then. They get the bonus of this. They can provide a little bit more. And this especially helps them out because, you know, the EBT cards and what they can get from the food pantry has limits. This tends to take some of those limits off. And that's one of the joyful things. It's I think it's hard to do something for one part of the family that does not in some way impact the children of the family. But when you can do it directly like that, so you know that you know, all those extra cartons of eggs that need to get used up within a couple of days now, get out there and the kids can have a few extra eggs. It's just a nice thing to make that connection. And community health workers in a lot of ways are making the unexpected connections. You hear about something and hear about the problem, and you begin to realize, I can solve the problem a different way by making this connection. A person that doesn't have enough income can often be benefited just by having a prescription help plan where they can reduce the cost of their prescriptions. That boosts their income. And so often it's listening and then just knowing what resources they have and how you can use that resource to address at least part of the problem. And it makes for a lot of fun just to be able to catch those connections and make them and take care of part of the problem and make it a little bit better.
I really appreciate, David, what you just said about making it fun too, because that's a really important aspect of this as well, is promoting fun and that kind of attitude in our communities. And I think in how this supports the health of our children, as I mentioned, working in the jail and working with adults, is how can we holistically look at this situation and address the different barriers and address the different things going on in a family's life. As they have a counseling or a therapy session, maybe once a week or once every other week, there is so much time in between there. And so how can we also be a bridge and be a continuous voice to say, hey, I know you had a really hard day yesterday, but I think you're doing amazing. Is there any other support that we can offer to you? And a lot of the times we will address these really quick, immediate needs and solve these problems, but there's still going to be a problem tomorrow. And how community health workers can jump in and say, okay, how can we plan longer term? How can we look at this situation and support this entire family to become independent and empowered to advocate for themselves as well? Because we don't want to create this wheel of dependency where we're constantly going and looking and doing the same things over and over again. We want to empower people to be independent, and that's a part of empowering parents to be involved, to be a part of what's going on in their kids' lives and be at the school, and making sure that kids are empowered to say, hey, this is what's going on with me, and vocalizing and advocating for themselves as well.
Thank you, Brooke. If we don't have any more responses to that, I think everyone gave incredible answers there and some really meaningful insight into the work you do. We're going to go to our next one. What are some of the biggest misconceptions? And I don't know that we've heard any of this in the answers that you've had, but misconceptions that you hear about CHWs. This is an opportunity to kind of clear the air, share what you hear that you want changed.
I'll start this one. Oh.
Okay, sorry.
I think that this does remind me of more of an academic discussion. I do want to hear what the folks on the ground are hearing, but in the policy world, there's this constant tension between professionalization and sort of community roots, right? The more community roots you have in your community health worker, sometimes that means less professionalization. And the flip side of that is, the more schooled you get and the more professional you get and the more you live in that sort of professional world, potentially the further you get from the community. And I think the misconception is just that, people tend to think about the extremes, and community health workers are really a delicate mix, I think, of both those things. You need to know enough to be actually useful and not just friendly. But you also do have to be able to identify with the people that you're working with. And more importantly, those folks have to identify with you. I don't think that community health workers can be successful if their clients can't see a little bit of themselves in the community health worker, and recognize that, that's the value of the community health worker. They came from the same place that I do. They're just like me in some ways, and maybe, maybe I could be more like that. That's the community health worker. They're the bridge between the community, where the community's at and where the community could be. And, again, I'm not sure if I'm answering this quite right, but that's always the delicate balance. I'm not sure if it's a misconception, but it's always tricky to navigate. And I think that's been true of community health workers since kind of the model started. You get someone out of the community, and when they start, all their connections are there. And then, you might raise them up to be a medical doctor, and all of a sudden they live in somewhat of a different world, but they still have those roots. sorry, I can't land that properly, but that's what this question made me think about.
No, I think you answered it really well. And you touched on a point that Eric had made previously about the import a professional model versus the building your own model up. And Eric, you can probably speak on this some more too, but we mentioned the transition of going from being a community health worker to ending up being a medical doctor, but still having those roots, which is a really important thing. In a very valuable part of community health workers is the opportunity to move up through the healthcare system. David had his hand up, and then Brooke, you were going to go when Steve started speaking too. So David, go ahead.
You know, I'd like people to consider kind of a different model of the way to become a community health worker. For me, it's a late vocation in life. I've got a bachelor's in psychology. I've got a Juris Doctorate. I've got a PhD in history. You know, to me, it was coming out to do something good. I finally got to that place where I didn't have to be so concerned about my income. You know, I'm reasonably well set up, so I could do something that begins to feel good. You know, my wife continues to practice law, which is, you know, great for the household and everything. But I got so sick of not doing anything that I consider to be valuable. And so I come to this way, and I think that would be a model to promote people who, you know, come to it as a vocation, you know, late in their career, where they're hoping to be able to give it. So in a sense, I would like it to become a misconception that community health worker is an entry-level thing, a thing where people are arriving and don't have that much formal education. You know, I'm not sure my 11 years of postdoctoral work at Boston College helps a lot, but you know, these are the things that I've placed aside to come and do something that lets me feel good about what I'm doing, rather than being something that I was trained for that I come to think was kind of hollow. And so instead I get to do something that I know is helping people. And so I'd like to see a multitude of different models about where people come from to get to this point of being a community health worker.
Thank you for sharing that. I didn't know that background on you, and I think that's a really key part of the model that we haven't talked about is second career. Maybe third or fourth in your case there. And then Brooke, you had your hand up a minute ago.
Yes. So I think it's really incredible, David. I loved hearing that background from you. I come from that opposite side where I was 19 when I started working as a community health worker. I've been doing this for a few years now, and I definitely get hit with a lot of, well, you're just a community health worker, or you're just this or that. And I've definitely seen quite a few people and quite a few doubters be really surprised when it comes to the skill set that I actually have. You know, I'm not just making things up as I go anymore. There's definitely a really deep skill set that community health workers can have of motivational interviewing, doing the case management work, having some baseline listening skills, things like that. That are really incredible. And so it's not just about a community health worker. And as entry level as this job can look, I think it can also be really complex. I think you could put somebody like David in here, and he has a lot of skills and a lot of knowledge, and he can take that and, you know, make it this really incredible thing. So I definitely see that people are not recognizing this as an actual profession, as an actual job long term. It's very much a short term thing where, well, we can place community health workers here to do handing things out. Well, yeah, you absolutely can, but they can also be a really important, crucial part of your team. And I've definitely found that that's a point that I'm at here, especially as we've been able to offer mental health services, is I can offer a lot of help in that area, in connecting people. And sometimes people don't even need that connection. Sometimes people truly, as I said before, want to be heard and seen. And that's enough to build that motivation alone. So I think community health workers are an incredible profession that you can enter at any point from anywhere. And I think that's the beauty about community health workers as well with their roots is you can have roots from all over the place. You can have knowledge and skill sets from everywhere and do something really incredible with that.
Very well put. Thank you, Brooke.
Hey, Haley,
Okay.
can I? This might be.
Sorry.
No, I don't want to take a whole lot of time because I know you probably have another question or two you want us to get to. But one of my dreams, and people will have to follow me really quickly, is that we invert the model for how we normally perceive of developing capacity throughout the state. And what we would end up with is a pyramid where at the bottom, we have an army of community health workers who are working in all corners of the state. And for some, it's their profession and it will be for life, for their entire 30 or 40 years. For others, it'll be something they do in retirement. For others, it'll be the start to another career. But we have this well-fed, well-watered army of community health workers who are really helping with every conceivable health and human service need. And then as you move up the pyramid, we have, our social workers, we have our master's level, and we have our doctors and nurses and so on and so forth. But I want an army of Davids and Brooks and Catherines. That's what I want out there.
Hey, I see your hand.
Can you hear me okay? I have trouble with this muting.
We can hear you, Catherine.
Okay, I just want to say that I flunked out of college like 3 times due to my mental health and addiction issues. So I have a degree in the School of Hard Knocks. And, through my mental health issues, I walked through a lot of unpleasant things that, if I'd have had a community health worker when I was raising my kids or, it just in later years, it would have been beautiful, but it didn't happen. And so I had to learn a lot of things the hard way. But anyway, I just want to say that I worked for like 33 years and I was a certified peer support specialist in Idaho for 2.5 years. And I took that training and then my business training and kind of put it all together. And then I became a community health worker and voila, I was able to use a lot of those skills that I learned along the way. So I'm grateful to be who I am, and I'm grateful that I get the opportunity to get the serotonin into my brain that I need naturally and then also synthetically, but I still am very grateful to my higher power for the opportunities that I've been given on a daily basis. And so thank you so much. And I feel very honored that you're listening to me. I know that it's very important to meet people where they're at. And I learned that skill along the way. So the misconceptions about CHWs are probably people are not aware of what we do. And I wish that it was more, I wish it was a little more, well, that people were more informed about what a CHW can do for them. Because I met with a gal the other day who just lost her husband, and she didn't have any other problems other than grief and, what do I do now? And so I met her where she was and was able to, just listen to her and validate her and be there. So we don't necessarily have to come up with a lot of complicated answers. It's just a matter of validation. Anyway, thank you.
Thank you, Catherine. Jay?
Yeah, so this ties in with what I wanted to share with the question, but like, what is being a professional? I mean, that's one of the questions that's out there. We have the word professionalization, but I kind of want to flip it, that it's not about the classes or the person as much as the respect that we give to people. And like, that's what makes a professional, is when we respect someone. And so maybe the misconception is just thinking of a CHW as a professional, that they don't have to use some version or standardized English to be a professional. I mean, we don't expect that in the tech community. We don't expect that in the real estate industry. Like, why should we expect it in the healthcare industry when we know that CHWs produce the outcomes that we want? And then I just wanted to tell one quick story. I was on a federal call, and a CHW had gone to go rescue somebody's dog while they were, going through a personal crisis and getting it to them. And because of that rescue, that person engaged the whole system. They were able to complete their carcinoid, some of their legal requirements. They were able to take care of their health requirements because somebody went and got that dog. The CHW that went and got that dog, that wasn't in the job description. It wasn't something that was allowed. Like, there was a policy in place for animals where they would go to a certain shelter. And, people who are doing that work burn out because we don't respect them. And so I'll leave it at that.
Thank you, Joe. So our final question here is, and then we'll move into some open questions. We have a few things in the chat. But why do you think AB 191 is or is not important? And so this is, how will Medicaid reimbursement impact your practice as a CHW or your academic view on CHWs? David.
In my job, I'm primarily allowed to do the things of a community health worker. After I get done doing the things is, making sure we're in compliance with all our grants. And because I can work at that quickly and I'm used to doing that kind of thing, and the county's happy with the reports, I get the time to do this. Where on the other hand, if we actually had funding that took care of some of the areas at least, then time would be made. There wouldn't have to try to fit it in doing something else just to get leave to be able to do that. And so it would make it a resource that would be dependable, that you can count on. There's a lot that goes on with Medicaid funding, and it's made a lot of programs available, and that's good. But this is another one where these services would really benefit by having somebody who doesn't need to squeeze it in. And I think that happens fairly frequently. That's at least my situation.
Yeah, hi, Lee, this is Eric. As Steve said earlier, community health workers in Nevada started basically with a grant. And that's how they've been funded since. We live and die by the grants that we have for community health workers. And so as an example, with our Resilient 8 project that's been funded federally, really was meant to be a demonstration project to show the capacity that community health workers could provide. So what AB 191 would do, it wouldn't necessarily address all the things that our community health workers do, because some of that is beyond the scope of AB 191. But those portions that would align, for example, when Brooke is meeting with inmates in the jail and doing some of that care coordination, and or when some of the community health workers, Dan and Naya, Esmeralda and Lincoln, are helping to hook people up with medication-assisted treatment, those could potentially be billable if they were under the supervision of an approved supervisor. And that would help with sustainability and really helping us to move forward with developing more robust capacity.
Very well put. Thank you, Eric.
I'd like to follow Eric here with that on the ground, I guess, as we're calling it, experience. So why is it important to have healthy, strong families and communities? In especially rural communities, we're not attracting professionals. It's just not going to happen. We don't have the flow here. We don't have the number of people here, or the type of lifestyle here that a lot of people truly enjoy living. So it's really difficult for us to attract those. And we live in a state where everything's so spread out, and we have so many rural and frontier communities that are not properly being addressed. Their needs aren't being seen, they're not being heard, and our people are suffering from it. And community health workers have the opportunity to be a step in and to be here and to say, we can help in this capacity. And I think this would offer more accessibility to our rural communities as well. Like Eric said, you know, these certain things can be billable under the right supervision, and we would have the capacity to be able to put more of us out there. It's more of that Army front line that we would be able to finally do and be able to support our rural communities in being healthy and being sustainable, because right now they're not. I can address and recognize that my community has a lot of barriers that could be helped by this if it was more attainable.
Thank you, Brooke. So we do have a few questions in the chat that I will open up to the floor here. Somebody mentioned that they are looking to return to the workforce and would like to do the CHW training. Do we have any tips for this individual?
Yeah, so we have 3 programs in the state, one in Nevada, one in Las Vegas, and one through the association. So I'll put the association link in here, and I'm going to put the other 2 programs on this same page, but I haven't done it yet. So TMCC and College of Southern Nevada also have programs. And then just a plug, it's not a CHW specific program, but CASAT also has a program, and they're looking at scaling up the number of students that they can serve, and that'll target you know, substance misuse and related.
And then somebody asked, are there any programs that encourage and help youth prepare for going into CHW work as a career path? It's not something I knew about until partway through my undergraduate degree, not something I knew about out of high school. Brooke, do you have a good story on how you discovered this path?
I think that question brings up a really good point of it's not a very well-known profession. It's not something that I knew about when I was in high school. Like I said, this happened very much by chance and through word of mouth. So-and-so knew this was going to be an opportunity, so I heard about it, and it all happened very quickly. I think it's something that we could focus on trying to do collectively, is how can we get more word out about this profession and get more people engaged and interested, because I think it's an amazing opportunity for younger people as well, who are invested in their community, who want to get involved in health and human services, because it's very achievable, it's very doable, and I think people at that age are very moldable. I was at a really good age where I was just a sponge to all of the information given to me. So it's something that brings up that really good point of how can we get the word out a little bit more that this is a profession that people can do.
Thanks. And then somebody else had asked, Brittany put this question in, how are CHWs supported when experiencing burnout? And has this support made a difference in turnover rates?
I'd like to touch on that. So I think that would vary by where your placement is and what you do. I personally have experienced some really high stress situations with my population that I work with. And one of the biggest things is having a team, having some really good open communication, and recognizing as well when it's out of your scope. I've had a lot of situations where I've been like, okay, maybe I can do this, maybe I can handle this. And it's really important that you have a team to be able to go to and say, hey, this is the situation. I really think I'm in over my head here. I don't think I can handle this, or I'm really getting stretched thin. I'm burnt out. And having a team and a group of people within your agency or your placement to rely on and say and recognize within yourself, you know, I need help here.
I agree with Brooke. This is Catherine. I would like to say that when experiencing that compassion fatigue or that burnout, it's important to recognize it in yourself and say, you know, I'm feeling irritable. I don't normally feel this way. I'm feeling pulled in 18 million directions. And I think Brooke spoke beautifully when she said, teamwork. Hand it off to a team member. You know, we are very team oriented here at the coalition. And so when I go to my supervisor and I say, man, you know, I'm really feeling like I need to take the afternoon, she's totally cool with that because she understands compassion fatigue too. So anyway, that's how I feel about it.
Thank you. Jay, do you have a plug for something that might increase people's network and team?
Yeah, so we have the association. I don't know if any of you know Grace Hayes. She's a musician in Reno, but she's writing us some music. So if you want to help write the lyrics, that's something happening now. She's already written some beautiful banjo music to go with it. And we're going to kind of transport you across the whole state to really increase the education of what CHWs are. But we also want to include more CHWs in the state advocacy, in our training development, because we're looking at another 4-year cycle where we get to work on those training materials. And so right now is a great time to come talk with your peers, share what needs you have, you know, access to therapy services or focus group or forget what that, processing groups. I love processing groups, and I have a few of those that help me a lot with some of the work that I do. So that initial pitch to get involved with the association, I put that link to the focus board. So there I'm going to put calendar invites of different things you could attend. There's a little application to join that CHW panel, and that's a minimum of 6 meetings a year, so it's totally achievable. But if you want to come every month, you can. And we'll just be all in the loop together.
Thanks for sharing that. And we are we're just 1 minute past now, but we're 1 minute past 10. Amanda, feel free to cut us off here when we're at our time, but I wanted to make sure everyone had a chance to ask any last questions. Oh, Assemblyman Ortlinker is still in committee and sorry, he wasn't able to join. All right.
And I can put in the link where he talks about the bill, because he did a great job.
That was last Thursday that you're referring to?
Monday, I think.
Oh, okay. Yes, Monday. All right. Well, if there is no further questions, thank you so much to everyone who was a part of our panel, everyone who asked questions today. This was extremely valuable. I've been researching with community health workers for a few months now, and I learned a lot being here. So really appreciate this time.